And good afternoon. It's Dr. Duke Majan at the Duke Spine Institute. We're getting ready to do a Duke laser disc repair L5-S1 left approach on a patient with bad back pain and left-sided leg symptoms. How long has this patient had these problems? Shot? Anybody?
6+ years.
6+ years. All right.
Almost grade 2 enterolistesis, right?
Oh yeah, there's a grade 1 almost. It's a grade 1 almost grade 2 enterolistesis, L5-S1. Yeah, it wasn't bad enough that we were doing the surgery. They have to make it hard for us, right? So we're gonna do our best to get down there and fix this problem. But it's not going to be easy. I'm having to change my entry point and try to find a way around because the enterolistesis, the facet arthropathy, all of that stuff is, oh, that's good. Oh. And for those of you who don't know, L5-S1 is the hardest to fix already. Then on top of that you add, on top of that you add enterolistesis and facet arthropathy and all the degenerative changes going on in the facets. It's awfully close. It makes it almost an impossible thing to do. Shot. All right, so let's go AP. Let's see where we are. And I'll show you in just a moment what I'm talking about. Wow, we're right there. So close. So this may be the best we can do. So very happy with the AP view. On the lateral view, I'm a little bit lower than I need to be. Makes it challenging. I'm going to have to try to renegotiate my trajectory. But Jordan, take another picture without the patient moving. All right, now show us a normal facet joint up above. Say around L3-4. You guys see these bones? Well, no, yeah, there you go. That's a normal facet, L3-4. Look at the facet down at L5-S1. It is massive. Circle it. Yeah, all the way back, even further back. There you go. All that is facet. Huge. And the reason why it's huge is his body is trying to compensate for what's called instability, which is essentially the movement of the spine forward. Our bodies respond to abnormal movement through hypertrophy of tissues or enlargement of tissues. And in this case, what's enlarging is the bones and ligaments at L5-S1. Shot? Shot? Trying to get my needle to go a little bit further north. Looks like that might have worked. Shot? Yeah. That's as good as we're going to get it. That's virtually impossible. The impossible dream. Shot? All right. So we're right there. That is, forget about level 1 through 10. That is less than a millimeter of space. That is literally the impossible. So I'm happy with that. Let's see if I can get into this disc so we can at least do a discogram. Wow, there it goes. We're in. I don't know how we did it, but we did it. I always say it's better to be lucky than good. So, honest to God, there's 100 endoscopic spine surgeons in the world that are the top. And of the top, probably 1 or 2 at most could get into that disc. That is the hardest to get into. Why? There's no disc space. You see the gap the needle's going in? Show us the gap. Okay, take a look at this gap. Right there. Look at the bottom of the vertebral body of L5 and the top of S1. The reason I'm pointing this out to you is because every endoscopic spine surgeon in the world that does transforaminal surgery would look at that and say it's impossible. and they wouldn't even try. It's important that you try, but just don't hurt the patient. Make sure you get a good fluoro, you get a good lateral, you prep the patient properly, you get your entry point right, you get your target trajectory right, and if you do that, then the impossible becomes possible. So what I'm saying is don't give up, but also don't hurt the patient trying. All right, we need our patient awake because we're about to do a test. Now, I get this question a lot. Dr. Duke, how do you fix the spondylolisthesis? Okay, here's the sacrum. Here's L5. Now, normally L5 is supposed to sit flush with, equal with the sacrum or tailbone. This is L5. But when you have a defect in the pars, which is the bone in the back that holds it onto the sacrum and keeps it from sliding forward, you don't want it sliding forward. We call that a listhesis. But in some patients, the listhesis happens. Lay still. And the L5 will literally slip forward on the sacrum. Huh?
You have a pars fracture, right?
Yeah, he probably has a pars fracture. Everybody with a listhesis like this has one. So you see the L5 is slipped forward now on the S1, okay, of the sacrum. That's where we are. And he has almost a grade 2 slip because he's right at the 25% mark and going into the, like around 30%, so that makes it a grade 2. Point I'm trying to make is we do a lot of laser surgery at L5-S1 or L4-5 and L3-4. We just did a patient earlier today that has 2 discs that are, or 2 bones that are listhesing. We're live, right?
Of course. Yep.
Yeah. And my point is, most spine surgeons look at this and say you need a fusion, but the reality is you really don't, because we fix the back pain from this all the time without fusing. And I just want people to know that. Are you awake?
How are you, my friend? You okay?
All right.
Good.
So the L5-S1 disc is
All right, I'm gonna
here.
ask you some questions, okay? All right, he said he's nodding, he said he's awake.
You comfortable?
Give me the thumbs up. You okay? Huh? You all right?
We need you awake for just a minute, and then we're going to put you to sleep, all right?
Okay.
Are you having any pain?
Any pain anywhere? Huh? He said no.
No pain. Good.
Yes.
How bad is that on a scale of 1 to 10? How high did it go?
12.
12. All right, 12 out of 10. All right, you can see, look at that. Look at all the dye coming back. That's all the pressure in the disc pushing it out. Show me an x-ray. Yeah, so you see how it was there and now it's gone? So here, we'll put it back, shot. All right, now, go ahead and show us, Jordan, where the tear is. Oh God, why did you take another picture? I didn't want you to take another picture. You got rid of the dye. All right, no worries. We'll do it next time. But you could see how I filled that damaged disc up like a balloon with the dye, and then it squirted it back out. All right, you get to go to sleep. When you wake up, we'll be done, and that 12 out of 10 pain will be gone. So let me just document that. Is that where you typically get your back pain? Yeah? Yeah, he said yes. So, folks, look at his spine. The other discs look perfect. On x-ray, on MRI, they look perfect. So what we're dealing with is an isolated, single bad disc causing all of his back pain, because the other discs are fine. And we just tested this one, and he said it was a 12 out of 10. We got that documented? Okay, now I'm just waiting for the patient to go to sleep.
How are you doing, my friend?
We're going to do some incision. Go ahead and count from 1 to 100 out loud. All right. Now, did you guys notice that when I did the injection, that his back tensed up? Did you all see that? And he said, ah, did you guys hear it?
I believe so. Yep.
Yeah, I didn't tell him I was injecting. So what that proves is I'm not telling these people, obviously I'm injecting, I'm just injecting. And they're, of course, experiencing the pain. And see the guide wire at 5-1 there? Beautiful. And we're recording their response. It's called an evocative discogram shot. And it's a wonderful test. It's the only test in the world that actually proves a disc is painful. There is no other test that does that. However, it's invasive. You have to stick a needle in someone's spine. So we try not to do that. We try to do it all without doing that. But now that I'm here anyway, and I had to stick a needle in the spine, hey, I want that information. Shot? So you might as well do the test because we have to be here and do this anyway. Plus, I need to add dye to the center of the disc so I could use it to find the herniation to remove. A little bit of num-num. Dr. Berndez's end-all to be-all. Be-all to end-all. Right? Just kidding. All right, here we are at that extremely arthritic facet. It's really big, enlarged, got a lot of soft tissue around it. That's the body trying to stabilize that segment, that area, and keep it from moving too much. Shot. Trying to stop the slipping on its own. All right, this is the side where he has a patient has a bad herniation in the left foramen, crushing his nerve root. Shot. Oh yeah, that's nice. But look at the guide wires right at the front. I don't want it going any further forward, so I'm going to pull it back a little bit. Shot. And give it some room to move. Again, it looks like the dilator is just going in, but it's actually sliding along a trail, a ramp, a path that's made by the guide wire. Remember, we put the guide wire in through the needle. Wait. So it's actually the needle that created the right path. Oh yeah, it's loose now. You can see loose. It's loose because the dilator is now inside the disc. I want to bring it just a little bit more forward, and we'll get rid of the guide wire, right? So the guide wire is sticking too far back. Proud. Thank you, Luis. So far so good. Patient sleeping. Go ahead, hold on, let me just see. Take the guide wire up. Now I've done plenty of these surgeries open with the patient's spine exposed, taking the bones and ligaments out. We call it a laminectomy, and then fusing. So I've done a lot of laminectomy and fusion for this problem. And in the end, the best result is the back pain's gone and the leg pain's gone. Well, the good news is we can do that without doing a fusion and laminectomy now with using the Duke laser disc repair endoscopically. Where do you see it? Why don't you pull the dilator back just a little bit? Not all the way. This patient has one disc that we're fixing. Shot. Back further. Shot. Where do you think? You think that's it right there? It looks like it's it right there, right? Yeah. All right, you can take it out. We're in far enough. Shot. Looks good. Perfect. You all see the tube inside the L5-S1 disc. Show them, Jordan, the tube. And this is the tube. It's a metal straw. It's what we're doing the surgery through. It's a tubular retractor. Wonderful thing. See how tiny the incision is? 7 millimeters. Everybody good? Here we go. And our patient is snoozing. I mean, snoozing, seriously snoozing. Very happily sleeping. That's what we like to hear. The snoozes, the Z's. Any questions from our audience?
No current question.
All right, so once again, we're treating back pain and leg pain in a patient with herniated disc, spondylolisthesis, stenosis, spondylosis, radiculopathy, annular tear, herniated disc, degenerated disc. All of those same diagnoses, which is almost every single patient, by the way, with a herniated disc or painful disc. All right. I'm sorry? He's perfect for us, yeah. We're very happy with him, laying still. He's not squirming around. like other patients whose names I shall not mention. Right?
Everyone's different under anesthesia. That's why
I
it's
know.
the practice
I
of
know.
medicine.
I know. Just giving you. If I didn't give you a hard time, who would? Seriously.
Luis
You-
wouldn't give you a
Luis would not. Luis would not. He's too nice. Your wife is not going to give you a hard time. Your son is not going to give you a hard time.
They're both
So,
nice.
right? They're too nice. So you need somebody like me giving you a hard time. That's my job. Ever since I was a kid,
I miss my son.
I'm the one who gives a hard time. Well, you need to bring your sons here, right? You need to bring them here. Then you could see them, you know? I feel very blessed that my son is here. It's the greatest thing I could ever have. To be able to work with your son.
I worked with him when I was at the surgery clinic. He was working.
Your son was working at the surgery clinic?
Yeah.
This was in where, Vegas?
Yeah. So I saw him every Tuesday, Thursday.
What was he doing there?
He's a personal assistant to the surgeon.
Nice. Before college?
During college, yeah. He
Huh.
was in high school too.
Nice.
So he's a junior now.
Don't move. You're doing all right. Lay still. Right, he's at UNLV, right?
He just got offered, he got a letter, he got offered 8 scholarships for his senior year.
8 scholarships. Wow.
That's going to help him out.
You must be very proud.
He sent me the letter yesterday.
I'm impressed. All right. We are now at the back of this painful disc, herniated disc, and I need to remove the last bits of this herniation that's sticking out, pushing on the nerve, okay? And we're going to see if we can take a look and see the nerve in just a moment. The nerve we're going to see at L5-S1 is going to be the exiting nerve root of L5. That's the one that's getting crushed the most. It's really the one that's being affected the most. L5. Some people don't know how the laser actually works. The way it works is the laser is a machine called the laser. It delivers a beam of energy that just for a burst of time, very short burst of time, that travels along the length of this glass fiber and exits right here where I aim it. And it delivers a really powerful energy burst to the tissue at a frequency of around what, 30 bursts per second, right?
Yes. It's
Or 30 bursts. What is it? 30?
hertz. What are the hertz?
What are the hertz? 15. All right, so 15 hertz. Laser on. So 3.5 joules or watts. All right, so yeah, it's about 5 minutes. Yeah, this is going to be a tough one because, well, now we're having a little bit of epidural vein bleeding. Just a little bit of the veins. Yeah, I'm not worried about you. These are just little veins, tiny, tiny veins, but what it does is I'm not worried about the bleeding. I'm worried about the fact that it makes it hard for me to see. And so I'm going to have to bring in the grabber, which is going to help me see better. Okay? That said, I just want to make sure we get everything here, get all the pressure off the nerve that we can. The nerve we're talking about is the nerve root. Again, the L5 nerve root, for those that want to know. And it's going to end up being right up there. I got to get rid of this stuff right here.
We have a question.
Sure.
This comes from Michael H. on YouTube.
Hello, Michael H.
And they asked, how many stitches will the incision require?
How many stitches will the incision require? 1. We always put 1 stitch. We do a subcutaneous stitch under the skin. It's reabsorbable, meaning your body will absorb it and it'll dissolve on its own. Oh yeah, he is snoring. Yeah, very nicely, as a matter of fact. So I'm trying to get here, this area that I'm working on now is called medial, M-E-D-I-A-L. Medial means, there's a bone spur. Medial means towards the midline. And not only am I trying to decompress the exiting root, but I want to make sure I get that traversing root as well, which would be the S1 nerve root. Watch the fiber. So I'm going to sneak in there with a grabber. That's going to give me a little bit better visualization. Is he okay? Huh? All right. There we go. Looking good. Just about done. I could see a lot of the herniation here is old and thick, hard, you know, calcified. We call it calcified. I do want to bring the grabber in one more time. All right, I'm going to try to take a peek up north towards the head and see this nerve root, okay? See if I can see it. Because I want to be, there it is. You all see the nerve root right there?
Yes, we do.
It's just above the blue line. That white thing is the nerve root, okay? That's how close we are to that nerve root, okay? That's why the herniation was crushing it, because it was squeezing out of this disc and it was hitting on that nerve root. I just want to get a little bit more. Normally we don't see the nerve root that good because it's buried in fat and, you know, it's not as compressed as it was in this patient. Let's see the grabber. So we're just about done, another minute. And if you have questions, feel free to ask them. I'll do my very best to answer them for you. But this is our last case, right? Then we have the plasma, which we're not broadcasting. So this will be our last broadcast for today. No? There's the nerve root there, just to the left. And what is that thing right there? Let me have the laser. I think that's fat. But I want to make sure whatever it is, looks like some fatty tissue that I hit with the laser. I don't think it's herniation. Yeah, it's fat. And then this stuff is just soft tissue. I don't see any more herniation on the nerve. That right there, maybe a little bit. I'm going to get that below the nerve on laser. I'm going to swing around, try the other way. This is just the top of the herniation, just below the nerve. I want to make sure it's not bothering his nerve, and it's not. And again, the patient is snoozing happy, very snoozing away. Okay, just about done here. We're done. I'm very happy we did what we could there, and I feel like we did a good job. All right. Great. So this is a one disc. We're not doing more than one. It's just the single one. And this patient had a herniation in the neuroforamen as well as a slippage. They had 12 out of 10 pain, basically horrible pain at that disc, and I think that pain's going to be gone, as it always is with the Duke laser disc repair. Duke laser disc repair is the best surgery in the world for getting rid of disc pain, pain from a disc that's injured. Any questions?
No current questions.
Excellent. Do we run any of our videos?
I do not believe so, no.
Why don't we run the video showing why does a herniated disc cause back pain? And then we can wrap up this broadcast after the video. Sound good?
Sound good?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.